Welcome to AETCM, the Emergency Medicine Channel. Today, let us discuss about ECG rhythm analysis. Last class, we saw some of the basics of ECG, how to take ECG, how to read about normal ECG, all these things. Today, we'll talk about rhythm analysis. Now, this one was discussed in the last class. ECG paper go in a speed of 25 millimeter per second. A small square is 0.04 second. A 5 squares or one big square, that is 0.2 seconds, and 5 bigger squares, that is in 1 second. So that is the speed of ECG. Sometimes these things are required when you are reading the ECG, but most of the newer ECGs will tell what is the rate, what is the rhythm, all these things. However, we should know the basics of ECG. Now, this also last class we have discussed. P waves are originated from the SA node. QRS is originated from the ventricle or AV node. These two things are very important to make a diagnosis of the rhythm of this ECG. Now you can see here, P waves are coming regularly. QRS also coming regularly. That means every P wave is followed by one QRS complex, and RR intervals, if they are coming in regular intervals, we can call it as the rhythm is in sinus rhythm. So that is very important. Now P waves are produced from the atria, that is due to atrial activation, QRS ventricular activation, and STT segments are due to ventricular recovery. This much is enough to diagnose the rate and rhythm of ECG. Other things we can learn in some other class. Now, how do you calculate the rate? Previously, yesterday we have seen the number of large squares you have to take. Here it is for 300 by 4. That will give you the rate somewhere around 75, 70, like that. Now, if the number of squares are large number, like here it is 7, so 300 by 7 will give somewhere around 43 beats per minute. Okay, so that is bradycardia. If the heart rate is very high, you can see here 2 squares are coming in between 2 QRS complexes, bracket QRS complex. So 300 by 2 will give you the answer somewhere around 150 beats. So that is tachycardia. So like that you can calculate the rate in ECG if the rhythm is normal. If the rhythm is abnormal, you have to go for 6-second method. That I am not going to that 6-second method now, because yesterday we have discussed that in detail. So this is 6-second, 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 beats are coming in that 6 second. So 60 seconds will have somewhere around 120 beats. They are irregular. That's why we are using this 6-second method. So heart rate can be calculated even by this method when the rhythm is irregular. Now, these are the causes for bradycardia. You have to search for 6 H's and 6 T's. If a patient is having bradycardia, most of the time they may not be symptomatic. If the patient is symptomatic, we have to treat the patient. But before that, we should know what are the reasons for bradycardia. Normally, hypovolemia, hypoxemia, acidosis, hyperkalemia, hypoglycemia, hypothermia, some toxins like OP poisoning, cardiac tamponade, tension pneumothorax, coronary thrombosis, pulmonary thrombosis, raised ICP, all these things can sometimes produce bradycardia. But if the patient is not symptomatic, asymptomatic bradycardia should not be treated. So that is very important. Some patients with bradycardia, if you investigate, sometimes you can see hypothyroidism. If you treat the hypothyroidism, it will revert back. Some patients who are having history of heavy manual labor in the past life, they also can have bradycardia. Some trained athletes, they can also have bradycardia, but all these fellows are asymptomatic, so no need to treat. Suppose a patient come with bradycardia and giddiness, vertigo, then that may be significant because he is having symptoms because of this bradycardia. Now, bradycardia also can be produced by AV blocks. So, AV blocks here you can see first degree heart block is prolonged PR interval. Normal PR interval is 3 to 5 small squares. Here it is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 squares are there. Small squares are there in between that P and QRS complex. So it is very high. That shows some problem in the bundle of his SNO2 AB node. Normally conduction happens without any problem. If there is a small problem here, the conduction will be slightly delayed. Here it is slightly delayed, take more time. So PR interval will be prolonged. Whereas in second degree heart block, one QRS complex after P wave. So P waves are produced normally. That means SI node is normal. SI node is normal. Then that current is not transmitted to ventricle. So QRS complex, it has to come here. It has not come. Okay, here also P waves are there. So atrial activation happens. One QRS complex has to come here. That has not come. So there are two types of second degree heart block, Mobitz type 1 and Mobitz type 2. Type 1 is called as Wengebach's phenomenon. Progressive prolongation of PR interval. You can see PR interval is lengthier here, more lengthier, more than the previous one, again lengthier. Suddenly one QRS complex is dropped here. So progressive prolongation of PR interval drop in one QRS complex. Whereas here there is no progressive prolongation, one QRS complex is dropped. Okay, so that is second degree heart block. There are two types, Mobitz type 1, Mobitz type 2. Whereas in last one, that one is complete heart block, AB dissociation. You can see here, P waves are coming in its own rhythm. So they are regular actually. So normally the after P wave, you should get a QRS complex. But what is happening? That is not coming. But QRS complex also coming regularly. But there is no actual association between QRS complex and P wave. So if you take RR interval, they are equal. If you take PP interval, they are also equal. But the normal U-shaped pattern of one QRS complex after every P wave, that is not followed. So that is a problem here. There is complete dissociation between atrium and ventricle. This is called as third degree heart block. Whatever it may be, first degree heart block may not be clinically very significant. You have to avoid drugs like beta blockers, calcium channel blockers, diltiazem, verapamil, like that. Second degree heart block, early heart blocks may not be problematic, but if you are repeatedly dropping QRS complexes like this, only P waves are coming, there is no QRS complex, 2-3 P waves are coming means ventricle is not activated and pumping is not happening. Patient can have severe symptoms because of reduced pumping. So high grade second degree heart block and third degree heart block can have symptoms of bradycardia, that is like difficulty, patient can have giddiness, vertigo, breathing difficulty, all these things. So that type of patients may be treated with pacemakers. So pacemaker has to be put for this type of patients. Now, management of bradycardia, it is very important. We have to see the treatable causes. If there is a treatable cause, we have seen that 5H's and 5T's, that should be ruled out. Then if there is no major treatable cause in that patient, if the patient is symptomatic, then the best option will be atropine. Atropine should be used in all patients who is having symptomatic bradycardia, whatever may be the reason. For example, patient with hyperkalemia can have bradycardia symptomatic. When they come to emergency room, we may not be knowing whether it is due to hyperkalemia or something else. So normally, doctor will give atropine. So atropine can be given transiently, it can improve the symptoms, but the actual treatment or definitive treatment is calcium gluconate. So whenever you are seeing a bradycardia, symptomatic bradycardia, before investigation itself, you can give atropine. So atropine is the drug of choice in significant bradycardia. If patient does not improve with atropine, then you can try for dopamine or adrenaline infusion, but definitive treatment is pacing. If the patient is symptomatic and does not improve with atropine, most of these patients may require pacing if patient does not improve with atropine or drugs like calcium gluconate in hyperkalemia, or some treatable cause like a patient is having pneumothorax and bradycardia. You relieve the pneumothorax, that can relieve the symptoms. If there is no other reason and severe bradycardia, or if there is second degree heart block or third degree heart block, patient is having symptoms, then you may have to give pace the patient. So pacing is required. You can see here permanent pacemaker is kept here. Temporary pacemaker can also be tried in conditions like severe poisoning, drug overdose, and all. We can try for temporary pacing. Now, tachycardia means heart rate is more than normal. Normal heart rate is 70 to 100. But if it is more than that, we can call it as tachycardia. Sinus tachycardia means there should be a P wave, then P wave should follow by a QRS complex, and the QRS complex come very fast. So heart rate is more than 100. You can call it as tachycardia. There are a lot of causes for tachycardia that is given here. You have to read about that. I am not going to that in detail now. But remember, if the QRS complex is more than 3 small squares, like normally you can see the QRS complex is less than 3 small squares. If the QRS complex is slightly wider and it is more than 3 squares, then you can call it as wide QRS complex. So tachycardias are basically divided into two important groups. One is sinus tachycardia and non-sinus tachycardia. Sinus tachycardia, there is a P wave and heart rate is somewhere around 100 and 120, that range. But the other type of classification is the heart rate, the QRS complex width. If the QRS complex is wide, then it is wide complex tachycardia. If the QRS complex is less than 3 squares, then it is a narrow complex tachycardia. Now, what is this problem? This problem is sinus tachycardia because there is a definite P wave here. PR interval is there. Then there is a QRS complex, and the QRS complexes are coming regularly, and the heart rate is somewhere around. There is a nearly 3 divisions. So 3 divisions means 300 by 3, 100. Heart rate is somewhere around 100 and 120. That can be considered as sinus tachycardia. It can be due to fever, it can be due to anemia, exertion, so many things, pregnancy. Now, the important thing when you are treating a tachycardia, first of all, you have to see whether it is a sinus tachycardia. If it is sinus tachycardia, reasons for sinus tachycardia, like I told already, fever is there, tachycardia is there. So the fever is the reason for tachycardia. Now, once you see tachycardia, you have to see the rate. What is the rate? You have to see. So, 2 QRS complex you have to take. In between, for example, two large squares are coming, 300 by 2, that is 150. So heart rate is very high. 150 is the heart rate. So first of all, you have to see what is the rate. So is there a tachycardia or not? That is very important. Second thing is whether the QRS complex is narrow or wide. Narrow means less than 3 small squares. Wide means like this. So more than 3 small squares. Okay, so that is wide QRS complex. So here what you are seeing, narrow QRS complex, but there is tachycardia. You can see only 2 large squares are there. So heart rate is around 150, somewhere around 150, 130 to 150 maybe the heart rate. Then there is narrow QRS complex, whereas here it is wide. QRS complex is wide. So basically tachycardia can be divided into two groups. One is sinus tachycardia and non-sinus tachycardia. In second classification, the non-sinus tachycardia can again be divided to narrow complex tachycardia and wide complex tachycardia. So that is a two important thing. Now supraventricular tachycardia means the tachycardia is originated above the ventricle. It can be the SA node itself or SA node like electrical activities surrounding that node. That may be extra nodal focus somewhere here. So that can produce conduction, or it can be due to atrial fibrillation itself. It does not come strictly under supraventricular tachycardia. That's a separate entity. But if you see that is also produced from the supraventricular area. So atrial fibrillation also can included in supraventricular originated tachycardia. It is not classified under supraventricular tachycardia, but the origin is above the ventricle. Now, supraventricular tachycardia means heart rate is very high. Normally, when the heart rate is more than 140 to 240, we call it as supraventricular tachycardia. There are two important reasons for supraventricular tachycardia. If there is an electrical activity goes inside the node, AB nodal re-entry tachycardia. So re-entry means normally the entry will be SA node to AV node. From there, AV node it will go to the bundle. But unfortunately, here the re-entry occurs here itself. So here itself re-entry occurs. That is AV nodal re-entry tachycardia. Sometimes it will be an accessory pathway. So here you can see the current goes to the SA node to AV node. From there, unfortunately, it goes through an accessory pathway. So accessory pathway normally occurs here, this area. So through this, either current can go in this direction or sometimes it can go back in this direction also. So depending on the direction, it can produce abnormalities in the ECG. Whatever it is, most of the time this supraventricular tachycardia is due to re-entry of the current either in the node or from the ventricle to atrium or atrium to ventricle. Both directions it can go. So AV nodal re-entrant tachycardia, AV re-entrant tachycardia, non-re-entrant tachycardia. So there are three types. Now, atrial fibrillation means you can see here, normally you have this atrium, ventricle, SA node to AV node, only one current is going, SA node to AV node. But if you have multiple foci like this, okay, lot of current produced from the various areas of the atrium like this. So normally SNO to AV node only P wave, one P wave will be there, one QRS complex will be there. Every P wave is followed by QRS complex. But here there are a lot of current produced from different areas. So that produces a wavy baseline. Then one QRS complex. When it is transmitted from the atria to ventricle, one QRS complex. But that QRS complex will be totally irregular manner because the rate will be totally irregular because the current from the AV node to SA node to AV node and after AV node to bundle will be randomly selected. So the duration will be varying. So duration will be varying. So that is irregular tachycardia. That is a feature of atrial fibrillation. So previously we have seen that whether it is narrow or not. That was the first question. Second question is whether the rhythm is regular or irregular. Regular means mostly it is supraventricular tachycardia. Irregular narrow complex means it has to be atrial fibrillation. Now, there are a lot of causes for atrial fibrillation like cardiac causes, mitral stenosis, mitral regurgitation, ischemic heart disease, hypertensive heart disease, congenital heart disease like ASD, cardiomyopathies, cardiac failure, myocarditis, thyrotoxicosis. One of the most common non-cardiac cause for atrial fibrillation is thyrotoxicosis, acutely pulmonary embolism, COPD, hypoxemia, alcohol. All these things can produce atrial fibrillation. Without any reason also patient can have atrial fibrillation, that is called as non-atrial fibrillation. Now multifocal atrial tachycardia means we have seen atrial fibrillation, there are a lot of foci which produces wavy baseline and QRS complex. Okay, but QRS complex is totally irregular. But in atrial fibrillation, multifocal atrial tachycardia means one P will be like this, next we will be in different morphology, next we will be in a different morphology. That is because atrial fibrillation multiple focus is producing. Here SN node, AV node, one conduction will be there. Sometimes another foci is producing current. Sometimes another foci is producing current. Sometimes yet another foci will be producing. This P wave, suppose this P wave is produced like this, normal P wave. This P wave will be like this. It may be slightly on this morphology. This may be smaller, but this morphology. This may be inverted because the flow is from down to up. Okay, so inverted view. So if you have more than three different morphologies in a rhythm strip, you are seeing in ECG rhythm strip, then you can possibly diagnose multifocal atrial tachycardia. This P is different from this P wave. This is different from this P wave. This is different from this P wave. So multifocal atrial tachycardia is mostly due to hypoxemia. Any condition which produces hypoxemia, you can get a multifocal atrial tachycardia. Here tachycardia is there, slightly irregular QRS complexes, but P waves are there and their morphologies are different. So that is multifocal atrial tachycardia. So wide complex tachycardia, previously we have seen narrow complex tachycardia, regular tachycardia, that is SVT. Narrow complex regular tachycardia, narrow complex regular tachycardia, that is SVT. But here what is happening? Wide complex, QRS complex are wide. It is due to an existing aberrancy in the conduction system. So you can have normal conduction system like this and you have tachycardia. So only you have narrow complex tachycardia. But if there is a problem in the left bundle or right bundle, or if there is an accessory pathway, all these things are aberrancy in the normal pathway. In that condition, if the patient develops tachycardia, the QRS complex due to some reason it will be wide. Okay. Whereas in without any aberrancy, it will be narrow. So if you are seeing wide complex tachycardia, then you have to always think that patient may have some sort of aberrancy in his conduction system, or it can be simply due to ventricular tachycardia. Ventricular tachycardia also will be wide. So wide complex tachycardia has got two important differential diagnoses. One is it can be ventricular tachycardia. Other one is it can be SVT with RBVB or SVT with LBVB or SVT with WPW syndrome. There is an accessory pathway. So there are multiple possibilities for a wide complex tachycardia. And narrow complex tachycardia has got only two important possibilities. One is AV nodal re-entry tachycardia or AV re-entral tachycardia. Okay. Now, wide complex tachycardia can be either due to LBBB or RBBB. But remember, when you have an RBBB with tachycardia, it follows the RSR dash pattern in V1. So, R, S, R dash pattern. Okay. R, S, R dash pattern in V1 typically tells you that this patient is having RBBB. Whereas LBBB, you can get wide QRS complex in V5, V6, and it can be either M pattern, the QRS complex will be M pattern, or it will be W pattern. Okay. Whatever it is, wide QRS complexes can be either due to RBBB or LBBB or due to WPW syndrome. If it is due to RBBB, LBBB, you can use the same drugs which we are using for supraventricular tachycardia. But if it is, unfortunately, if it is due to WPW syndrome, if you are using same drug, sometimes it can aggravate. That's why in wide complex tachycardia, we always use amiodarone as a drug of choice. Now, ventricular tachycardia, we have to know in detail. If you are getting one beat like this, normally QRS complex are narrow, so two QRS complex narrow. In between, if we are getting a wide complex, we tell that it is ventricular premature complex (VPC) or ventricular ectopic. If two ectopics are coming in a row, this is most of the time innocent problem. If two ectopics are coming in a row, we call it as couplets. Two ectopics are coming. During that period, normal QRS complex has to come here, it has not come. So two ectopics. that will not produce any effective pumping. That ectopic is only electrical activity, pumping is defective. But if 3 are coming, then you can call it as triplets. Then onwards, you can call it as ventricular tachycardia. The problem in ventricular tachycardia is the ventricle is not beating properly. It produces electrical activity like this larger QRS complex are produced, but the beating is not properly. So this patient can arrest any time. He can have hypotension shock. Some patients may initially have normal BP in ventricular tachycardia, but eventually they develop hypotension shock, cardiac arrest. So that is very dangerous situation. It is VT, wide complex tachycardia. One of the reason is VT. Now, if the wide complex tachycardia sustains more than 30 seconds, you can call it as sustained VT. If it is non-sustained less than and it is less than 30 seconds, you can call it as non-sustained sustained VT. Now, wide complex tachycardia can be due to SVT with aberrancy. Here, what you are seeing SVT with LBBB that produces wide complex tachycardia. But whereas in wide complex tachycardia also can be due to VT. So very easily you can make out this one. Sometimes it will be difficult also. SVT with aberrancy follows the usual pattern of any ECG. Like here, some QRS complex are negative, some are positive, you can see here, whereas in VT most of the ECGs are either negative or they are positive. Here everything is negative, so it's a VT. But it is very difficult clinically to make out whether it is SVT or VT for an average doctor in emergency room. So that's why in ACLS protocol it is only wide complex tachycardia. Whether it is SVT with aberrancy, whether it is SVT with due to SVT with WPW syndrome, whether it is VT, treatment all are similar. Now, if wide complex tachycardia, if they are irregular, you can see here normally if you draw a line, this is the axis. Some are going up, some are going down. So this is called as twisting of axis. So axis is twisted like this. So that is called as Tosadis D point is that's a type of VT. So here we may have to use magnesium sulfate. Now, ventricular fibrillation, if you don't treat the patient properly, then the VT can sometimes lead to ventricular fibrillation. Here, ventricle is only fibrillating like this. There is no effective pumping. So, VT itself, the pumping is reduced. Some patients can have BP, but most of the patients may not have BP. They eventually develop hypotension shock. And most of these patients, this is the end problem. They can develop ventricular fibrillation. You can see ventricular tachycardia leading to ventricular fibrillation here. Then if you don't treat properly, patient will develop flat line, that is the asystole. Now, when you have a tachycardia, if you know that it is SVT, then you can go for carotid sinus massage. Then you have drugs like verapamil, diltiazem, metoprolol, amiodarone. Amiodarone is one of the useful drug where amiodarone can be used in almost all types of tachycardias. Whereas metoprolol, diltiazem, verapamil, you should try to avoid in conditions like WPW syndrome. But for a normal doctor who is in emergency room, he may not make a full diagnosis of tachycardia. That's why ACLS says wide complex tachycardia better to go for amiodarone. But if you know that it is due to SVT with LBBB or RBB, you can definitely go for the drugs like verapamil, diltiazem, or metoprolol. Or if you don't know anything, better go for amiodarone. The patient is in hypotension, shock, all these things, then synchronized cardioversion will be option. When you are reading about ACLS, you will understand this. So we have discussed about one of the important topic, how to diagnose the rate and rhythm. I didn't discuss the treatment in detail here. We are only making you how to read the ECG properly. We have discussed about rate and rhythm, common types of tachycardia, whether it is narrow complex tachycardia, wide complex tachycardia, regular tachycardia, irregular tachycardia, all those things we have discussed. Thank you.